Hi, everyone, and thanks for listening. Thank you for joining for today's Cancer Survivors Park Prevention and Wellness Series presentation. My name is Julia Humphreys, and I am with Gibbs Cancer Center, and I'll be your host today. Today's topic is one that may be new to many of you, the use of radiation therapy for benign conditions, meaning conditions that are not cancerous. So this is different for us. It is my pleasure to introduce today's speaker, Dr. Daniel Freed. Dr. Freed is a radiation oncologist here with me at Gibbs Cancer Center, and he has been a valued member of our team for many years. He earned his medical degree from the University of North Carolina at Chapel Hill and went on to complete his residency training in radiation oncology there as well. Dr. Freed is not only known for his expertise in radiation oncology, but here he's also known for his really thoughtful and compassionate care that he provides to our patients every day. So we are very fortunate to have him with us today to share his knowledge and perspective on this important topic. Dr. Freed, thank you so much for being here. I'll turn it over to you.
All right, thanks very much. I really appreciate the opportunity to be able to talk with you all about radiation therapy for benign conditions. Again, something maybe a little off the beaten path for most of our folks used to hearing about cancer, but using sort of cancer-related technology for treating benign conditions. So this has created a little bit of an identity crisis for us in the world of radiation oncology. I mean, we've always considered ourselves to be oncologists, and all of a sudden, we're treating a bunch of patients who don't have cancer. I work at the Gibbs Cancer Center, and here we are treating a bunch of arthritis patients and so forth. So it's been a little bit of an adjustment for us. And frankly, a little bit of an adjustment for some of our new patients who can find it to be a little bit intimidating coming into a cancer center to have treatment for a benign condition. So what we try to do is try to alleviate some of that anxiety that can be associated with being in a cancer center and let them know that really we are shifting more toward thinking of radiation as a means of treating a wide array of different conditions, not just cancer. So here's a cartoon that sort of sums it up. He says, so you're saying that you can fix my tennis elbow with the same machine you use for cancer, but gently? And that is actually exactly what we're doing. So you see in the background, there's a linear accelerator there. That's the exact same machine that we use for treating cancer patients, but now we're treating benign conditions like tennis elbow or golfer's elbow and other types of conditions. Now, there are a lot of different benign conditions that can be treated with radiation. I've tried to, I mean, this is a little bit of a busy slide, but it just gives you a little bit of a sense of the breadth of what we are treating with radiation these days. More than 20 benign conditions are treated with therapeutic radiation. To, again, try to make a little bit of sense of this, I've divided it here into in thinking about the dose of radiation. So on the left upper part, you can see LDRT, that's low dose radiation therapy. And this would include treatments for things like arthritis and tendonitis, bursitis, plantar fasciitis. Slightly higher doses, but still not quite the dose that we would use for most cancer, can be used for hyperproliferative disorders. We're going to talk in detail about something called Dupuytren's disease or Dupuytren's contracture coming up momentarily, but we also treat things like keloids or prevent the development of bone formation in places where it shouldn't be following big surgeries and things like that. We also can treat skin conditions, though I'll say frankly at our center we're not currently doing that, but that's sort of on the horizon for us. But one thing we are doing a lot of is treating stereotactic benign conditions, and that is the use of very high radiation doses to treat things intracranially or inside of the head. So that would include things like meningiomas, which are just benign tumors, acoustic neuromas, also benign tumors, but things like trigeminal neuralgia, which is a pain condition, or even movement disorders. And we're going to talk in detail about movement disorders coming up momentarily. And then just sort of a miscellaneous group of other things. So again, quite a breadth of things that we're now treating with therapeutic radiation therapy, not just cancer. These are the three areas we'll focus on today: arthritis, Dupuytren's disease, and movement disorders. So just to give you an overview, first I'll talk about low-dose radiation therapy for osteoarthritis. How does it work? what sites can we treat and not treat? How well does it work? Who should we be thinking about for using this type of approach? And what are the potential side effects? Also for Dupuytren's disease, which a lot of you may not think you know about, but when you find out what it is, you may say, hey, I know somebody who's got that. But what is it? What are the standard management approaches? Who should be a candidate for radiation therapy? And how well does it work? What are the side effects and so forth? And then finally, we will talk about tremors, both Parkinsonian tremor and essential tremor, in terms of where radiation therapy fits into the more conventional treatments that are used. So before we get too much into this, let's talk about the elephant in the room. Okay, most people know two things about radiation. One, it causes cancer. And two, you can use it to treat cancer. So the reality is, yes, it can cause cancer, though it does it at very low rates. And depending on where you treat, what kind of dose you're treating to, the age of the patient, and a variety of other factors, it either is or is not a really big concern. So, for example, when we treat peripheral areas for arthritis or tendonitis or something like that, there's very little active bone marrow in those areas. And it's exposure of those areas with active bone marrow to radiation that can cause issues with the formation of cancers. So when we treat extremities with low dose radiation for arthritis, our risk of inducing a cancer is actually quite low. The more active bone marrow there is, the higher that risk becomes. And so this is one of the reasons why when we are thinking about treating arthritis, we don't treat the joints of the spine, for example, because the vertebral bodies contain significant active bone marrow, and that actually does have a significant risk then of us inducing a cancer.
Dr. Freed, I'm really glad that you touched on this because I think when people hear the word radiation, right, like you said, they immediately think cancer, something scary, something pretty risky.
Right,
They don't
exactly.
necessarily think that it could be used to treat different conditions. So I'm really glad that you're highlighting this, but I do have one question for you about it.
Sure.
In terms of when patients are coming into the room with you, are you finding that they're a little bit hesitant, even though they do want to pursue learning more about the treatment?
Yeah, sure. I think there's a little bit of anxiety about being in a cancer center, but also being potentially exposed to radiation, which again, they're concerned might be something that would cause a cancer. But as we'll see upcoming here, I'll show you, the rate of that cancer formation is quite low, especially when we're dealing with the extremities. And the type of cancer that can be induced is, generally speaking, a basal cell of the skin, which is a highly treatable cancer. And the latency for that, that is the time from exposure until you might develop a cancer, is 20 to 30 years. So for most of our arthritis patients who are, say, 60 years of age and older, the thought of when they're 90 or 100 years old developing a skin cancer, which could be excised by a dermatologist, and that they have maybe a 1 in 1,000 or 1 in 2,000 risk of that occurring, that once they understand what the odds are and what they're dealing with, it becomes less intimidating. So again, here, as it says, the latency for solid malignancies, and in this case, again, most commonly that's going to be a basal cell of the skin, is 20 to 30 years or longer. However, when we treat the spine, what it can induce is actually a leukemia, obviously a much worse cancer, and the latency for that is only 5 to 10 years. So that's a much more concerning situation. And this is why when we're treating these benign conditions, we avoid treatment of the spine. So here you can see also some age dependency. So the longer a person has their life expectancy is, the higher the probability is that they might develop a cancer as a result of exposure to therapeutic radiation. But even for patients in that 25-year age range, it's not a very high risk. And some people wind up, I mean, usually we're not treating people in that kind of 25-year age range. We're really most commonly treating people 60 years of age and older. So let's talk a little bit about low-dose radiation therapy for arthritis. First of all, let's talk about arthritis. It is a big problem. Over 32 million people in this country suffer from arthritis. Well, that's about 10% of the population. And in fact, this is a very rapidly increasing health condition in the US, and it is currently the second leading cause of disability in the United States. So with aging population, that's going to become more and more prevalent. Here you can see the lifetime risk by male and female for various sites, but you can see that the most common things are going to be knees, hands, and hips. And in my practice, this is what I see on a routine basis. By far, the most common thing that I am treating currently is knees.
I don't think there's any of us out there that can sit here and say, "Oh, I don't know someone that is suffering from this." So I think this is very informative for
Yeah,
sure.
well, the amazing thing is just how word of mouth is sort of spreading
Mhm.
and that we have people come in all the time. The other thing that happens is I'm treating a prostate cancer patient or something like that, and he's talking about how, well, he's doing fine as far as that goes, but his knee is killing him. And so it isn't uncommon that we wind up actually treating some of our cancer patients with low dose radiation for arthritic issues. So here you can see, okay, the standard management of osteoarthritis. I think this pyramid shows you pretty well kind of what the common things are. That we start off at the bottom of the pyramid with these relatively conservative approaches. These would include education, exercise, weight loss, um, use of aids like canes and braces and so forth. And also one thing that they don't have listed here, but that is physical therapy, very commonly used kind of in the early setting. And all these things are very effective for early arthritis. Once those things are not fully taking care of the situation, then patients will move on to either usually topical agents like nonsteroidals and capsaicin, and then to oral medications like the NSAIDs, acetaminophen, and so forth. Now, this is a very logical and orderly progression up the pyramid. And then things get a little bit murkier because after that, we have mostly things that are like injectables, particularly for the knees, so, but any joint, intra-articular injections of steroids, very common. Or these days in the knees, the use of gel injections with something called hyaluronic acid. Euflexa would be the most commonly used one of those products. Um, these can work quite well to try to put to reestablish some distance between the bones instead of having them kind of grinding bone on bone. But the durability of them is fairly short. And the other thing is with steroid injections, they tend to start off by working for a good long while, maybe 3, 4 months. And then as you get more and more of these injections, the durability of that relief becomes less and less. The other thing to know is that those injections themselves can cause further deterioration of the joint. And so we wind up then with a lot of patients getting to the top of the pyramid where really the main thing that they can do is to have a joint replacement. And that is a big deal. And there are a lot of patients who are not good candidates for that. So what's missing from this pyramid? Well, you don't see low dose radiation therapy anywhere on this pyramid. So mostly now we are occupying the space between the two top tiers of this pyramid. That is uh, when the short-term injections and things like that have not been or ceased to be effective anymore, but the patient is not ready for surgery yet, either because they don't want to do it or maybe they're just not surgical candidates. So this is kind of frequently where we are in the pyramid, though we really are appropriate to be even maybe one step earlier in that pyramid before people have exhausted all of those options, either kind of right around the same time as that, or even slightly before that, because the side effects from low dose radiation therapy are very, very limited.
Yeah, I was going to ask about, once you get to the point of needing the shots, I think that becomes more invasive, right? And so I think maybe people listening may be thinking, what if I didn't want to be as invasive? Could we come down a notch on that pyramid and place the radiation therapy there before going towards the shots and the surgery. So you're saying that that may be an option for
It
some
may be an
people.
option, but we want to do this in conjunction with our orthopedic colleagues
Sure,
instead of so we want to just, make sure that we're doing things in conjunction with them rather than trying to in any way replace them because
of course.
really the majority of what takes place here is going to be best managed by orthopedists.
Good information. Thank you.
All right, so let's talk a little about history, okay? So Wilhelm Röntgen discovered the X-ray in 1895. So that's a long time ago, right? Over 130 years ago. Well, the first paper published documenting the utility of low-dose radiation therapy in the treatment of arthritis was published 3 years later in 1898. So we have known that low-dose radiation therapy can be effective in treating arthritis for 128 years. And in fact, it was used quite commonly even in this country up until the 1980s. At that point, though, pharmaceutical companies started developing all sorts of prescription medications. And so we saw a sort of a wholesale replacement of low-dose radiation therapy with pharmacologic agents. In addition, at this time, people were gaining a greater awareness of the possibility that radiation might cause cancer. Again, they didn't understand the specifics of it or weren't aware or weren't informed of that in order to sort of alleviate that. So instead of trying to alleviate some of that anxiety, they just sort of allowed the transition into fully therapeutic or pharmacologic agents for these therapies instead of radiation therapy. Now, if you look at Europe, though, those prescribing patterns did not follow the same course. That is to say, especially in Germany, they continued to use low-dose radiation therapy throughout. In fact, there was a big study back in 1998 that was trying to assess the use of low-dose radiation therapy for osteoarthritis in Europe versus the United States. And what they found was that at radiation centers, over 85% of them were doing treatment for arthritis in Europe, whereas less than 10% were in the US. And I would argue it was really close to zero. But if we look at the prescribing patterns in Germany, fully a third of the treatments that are delivered at radiation centers are for benign conditions today. The primary ones being osteoarthritis and tendinitis. So very, very common. And in fact, in terms of tendinitis, one of the really interesting things that I saw recently was a video of Usain Bolt. So Usain Bolt, maybe the greatest sprinter of all time, probably the greatest sprinter of all time. Well, in preparation for the 2016 Rio Olympics, he had significant Achilles tendinitis and plantar fasciitis. And he had tried all sorts of things to try to address this problem, but he wasn't able to train properly. And eventually he became desperate. He went to Germany and actually had low-dose radiation therapy for those issues. And his symptoms resolved. He went on to win 2 more gold medals. So, but there is actually a documentary on his life that includes showing his trip to that center and the treatments that he received. It was really quite interesting. So anybody who wants a fun video to look at, they should take a look at that.
Do you see those percentages changing in the future, Dr. Freed?
The percentages here
Right, for the use
with
in the
the
US.
European
What
versus
do you
US,
see those
absolutely,
trends?
they are changing dramatically as we speak. So in our own practice 2 years ago, we didn't do any of this treatment. I would say right now, about a quarter of my patients are low-dose radiation therapy patients. So it has been a
Wow.
dramatic change for us, and our patients have really done amazingly well. So let's talk a little bit about conventional radiation doses versus what low-dose radiation therapy is. So conventionally, and that is when we're treating cancers or even benign conditions, typically we're using much, much higher doses than we use when we're treating for arthritis or other inflammatory conditions like tendinitis or plantar fasciitis or bursitis or something like that. So with cancers, typically we're treating a dose of 40 to 80 gray. And gray is just a measure of how much radiation, but just bear in mind, that's a pretty high dose. And we do it typically in a bunch of treatments, and we call our treatments fractions. Okay, so each treatment is a fraction. So typically 40 to 80 gray given in 20 to 40 fractions would be kind of a standard type of treatment for a cancer. For benign conditions, we often go to a lower dose, typically more kind of half the dose that we do for cancers, but still it's a fairly significant dose, anywhere from 15 to 50 gray in 3 to 30 fractions. With low dose radiation therapy, on the other hand, the dose itself is much, much lower. So our typical regimen is a total of 3 gray delivered in 6 fractions. So at half a gray per fraction, and typically given either 2 or 3 times per week. So it is a much, much lower dose. And in fact, they're even looking at studies of what's called ultra low dose radiation therapy and looking at 0.05 gray instead of 0.5 gray. And so far, no data to tell us that this actually works, but we'll be interested to see, because if it does, then the number of treatment courses that you could do in a lifetime is essentially unlimited. All right, so how does it work? I'm not going to get too much into the weeds about this, but just to say that it acts by both decreasing inflammation and by increasing what's called osteoblast activity. That is the activity of the bone forming cells. So it actually can repair joint damage because it has decreased the inflammatory response. So it does that in a variety of different ways. And this is a very good schematic that really goes into the details of that. And for anybody out there who is interested in the sort of really getting into the nitty-gritty of it, you can look up this article written by Austin Dove and colleagues, published in the International Journal of Radiation Oncology, Biology, Physics back in 2022. But this is a very, very good article for those people who are very technical. Okay, so what sites can you treat with radiation in terms of treating arthritis? Well, there are lots of them that you can treat, including knees, hips, hands, ankles, shoulders. Here it talks also about plantar fasciitis and elbow syndromes and so forth. All these things are known to have good data to support their use in the treatment. This is actually by an organization called DEGRO. This is basically the German organization that makes recommendations about the use of therapeutic radiation therapy. And so they feel that all of these sites are appropriately treated with low-dose radiation therapy. So, okay, what happens for a patient who comes to the cancer center to get treated for arthritis or for any of these other benign conditions? Well, the starting point is a consultation visit with a physician, during which time there's examination of that joint or wherever the problem area is, and an imaging review. Now, often patients think they have arthritis when they may in fact have something else going on. So we really do need imaging studies to show us that in fact this is what the problem is. If they don't, then we will acquire those imaging studies. And usually it's as simple as just getting some plain x-rays of a knee or of a hip or something like that. And usually it's very obvious that they have some amount of arthritic change going on. Then we usually talk about, okay, what is our expectation of the effectiveness of radiation in this situation? Because our expectation is based very much on how bad the problem is. That is to say, arthritis basically comes in 4 stages, right? Stage 1 is very early and barely has any symptoms at all. Stage 2, you're really starting to become quite symptomatic. X-rays start to show changes, but nothing really dramatic. Stage 3, you're seeing real loss of joint space, and it becomes much more debilitating. But the stage 4s is true kind of bone on bone, complete loss of joint space. The cartilage is completely destroyed and so forth. And these patients are really very, very debilitated. For radiation therapy, the sweet spot really is stages 2 and 3. Once we're into stage 4, our expectation of the effectiveness goes down. So our success rate is somewhere in the 80% range for those with stages 2 and 3, and that is success in terms of achieving good to excellent pain control. Once it is stage 4, that goes down to more like 40 to 50%. So we just have to be realistic in our discussion with our patients that if they have very advanced arthritis, that the probability of success is going to diminish. And then we do have a discussion of side effects, which we'll talk about in just a second as it comes up. But I'll just cut to the chase and say that side effects are usually very minimal and mild. Once we've decided that we're going to move forward with things, we do what's called a CT simulation. This is a special CT scan, and there you can see one CT scanner in the picture there. But we have to immobilize the patient in some way in order to make sure that the treatments are reproducible from one day to the next. Then we sort of do a dry run of that where we take x-rays and so forth. And once we have verified that that is set up properly, then they begin those daily treatments. The treatments themselves take about 5 to 10 minutes. They're completely painless, like getting an x-ray, and they are x-rays. So as you would expect, you can't actually feel it when you get this radiation treatment. Now, while patients are on treatment, the doctor meets with them, usually as they get toward the end of the treatment course to get an idea of what kind of relief they're getting from their pain and also to discuss whether they're having any side effects. So this just shows you a few of the different immobilization techniques. You can see up at the top left, this is a patient actually with getting a shoulder immobilization, but in order to really immobilize the shoulder, well, we kind of immobilize the whole head and neck region as well as the shoulders. But various different fancy bean bags or thermoplastic molds are used to be able to set the patient up so that they can be in a position that is highly reproducible from the initial CT scan to all of the treatments that they'll receive. So again, pain relief, somewhere between 60 and 90% of patients say they get good to excellent pain control. The durability tends to be about 1 to 2 years. But because it is such a low dose, we're able to repeat that a number of times. And I will say this, that in general, when we do this type of treatment, we wait about 10 weeks then to do an evaluation of how they have responded. The reason for that is that the timing of the pain relief that they get is highly variable. Some patients, after a couple of treatments, are already seeing significant pain diminishment. Others may not have any improvement during the actual treatment course, but in the weeks following treatment, they actually start to have improvement. So we wait about 10 weeks before we do an evaluation to assess, okay, how'd they do? What I have found, and what is generally the case, is that patients fall into 3 groups. At the bad end, patients who got no relief whatsoever, and that is about 20% of patients overall. On the very good end are the patients who got complete relief of their pain, and that also is about 20% of patients. But in the middle, we have about 60% who get partial relief of their pain. Now, for many of those patients, we go on to do a second phase of low-dose radiation therapy that's just like that first six treatment phase that we had done previously. And that improves upon the durability of the relief and sort of improves upon the amount of pain relief that they have gotten. Now, over time, we think that patients can go through about 8 of these treatment courses to any individual joint area. So if they're getting good relief for a couple of years or so, and then it needs to be repeated, that's certainly not a problem. But once we get beyond, 8 treatment courses, then we start to worry that we're going to actually start causing significant harm to the joints rather than improving that situation. So now let's talk a little bit about side effects. So I said the side effects are minimal and mild, and that has been shown actually in a randomized controlled trial of this radiation course versus what's called sham radiation, where you turn the sound of the machine on, but you don't actually turn the radiation part on. And it turns out the side effects for the two were identical, meaning that the side effects from radiation therapy were no different than a placebo. In theory, you could get some skin irritation, and about 1% is the rate that has been seen, though I'll say in my practice, I have not seen anybody with a significant skin reaction. And The other things to note, there is no negative impact for patients who do want to go on to get surgery in the future. So, whereas high doses of radiation therapy for cancers, they may actually cause difficulty with surgeons being able to operate in the future, but that is not the case for low dose radiation on the ability of a surgeon to go and do a joint replacement in the future. And there are no actual reported cases of secondary malignancy in the reported literature, though we know again that there are these theoretical issues and that there could be cancers that form as a result. Now, we are in the process of trying to change people's thinking from now. I'm going to show you two real radiation signs that wind up in places. Okay. This one says, watch out for radiation. You better run or you're going to wind up dead. Okay. And that is kind of how people have thought about it. To this one of my more favorite ones, where we refer to this as the gentle healing beam. Okay. So that's where we're trying to get people's minds, is to understand that radiation in this setting actually is very therapeutic in terms of its ability to calm inflammation, to improve people's pain symptoms, and actually to help healing of joints. So who should be considered for low-dose radiation therapy treatment? Well, those who are treatment refractory, meaning those who have tried all the conservative and medical management options, certainly, and that's, fairly high up on that pyramid that we had been looking at earlier. But bearing in mind that it is less effective for those with true bone-on-bone situation. Those patients who are intolerant of medical management, that is, they're having GI bleeding from non-steroidals and things like that, or they have bleeding disorders or other contraindications to NSAIDs, or renal failure issues where NSAIDs are contraindicated and so forth. So these patients who really are not appropriate for medical management may be appropriate for low-dose radiation therapy. And a lot of patients that we see are either inoperable or marginally operable because of their age, because of obesity issues, because of medical comorbidities, or just an unwillingness to undergo surgery. And I will say we have a large group of patients that are not surgical candidates because primarily of obesity, but they're in a very difficult situation because in order to lose weight, they need to be able to be more mobile, but they're immobile because they have too much pain from their arthritis. So the prospect of them losing the weight necessary to become operable is not very good. But with the addition of radiation therapy, the hope is that we make them more mobile, they can lose the weight that they need to, and then they can become good surgical candidates in the future.
I have to say, Dr. Freed, listening to all of this, I'm learning so much myself. So I can't imagine what the listener is learning while they're listening to this. But to me, it just seems a lot less intimidating and a lot less disruptive than I think anyone would think when they're thinking about this in terms of low dose radiation. So tell me, when a patient is sitting in your chair after it's all said and done, do you kind of see that like, oh, this is a lot easier than I thought it was going to be? Do you hear that?
Absolutely. Yeah.
Mhm.
And because, I mean, again, it's intimidating to be in that environment and they feel like, oh gosh, it's a lot that they're going to have to go through. But then when they are actually going through it and they see, I actually don't feel anything, I'm not getting any side effects, and I'm getting improvement in my pain, then it makes things a lot easier. They become more relaxed and sort of, it again becomes a much less intimidating situation. Okay, let's change gears a little bit. First, we're going to talk a little bit about Dupuytren's disease. So, uh, many of you may want to know, what the heck is it? Um, and a lot of people have seen it, but just not known what it's called. So it's basically an abnormal thickening of the palmar fascia. It develops initially as just nodules and thick bands of tissue in the palm of the hand. And over time, as it worsens, those bands start to contract and cause the fingers to bend in toward the palm so that you can't actually straighten them anymore. It's actually quite a debilitating condition if it's allowed to get to its kind of most extreme. It has been documented for a very long time. In fact, first described in the medical literature in the 1600s. And it is very, very common with a worldwide prevalence of 8%. There are certain things that are more predisposing to it. Patients who are alcoholics tend to have a higher risk of it. Type 1 diabetics have a quite high risk of developing it. And it is very strongly inherited in certain populations, mostly those of Northern European descent. Um, some of the factors that are associated with the aggressiveness of it have to do with gender. So men tend to have worse contractures than women. Early onset tends to go along with a worse prognosis. If you have it in both hands, it tends to be worse than if you have it only in one hand. And first degree relatives who have significant condition also can predict for having it and for it being more aggressive. Also, these lifestyle factors such as alcohol, tobacco, and manual labor go along with a worse and more aggressive Dupuytren's disease. So it comes in different stages. The first stage can be broken really into two. There's an end stage, which really is just before stage one, and that is when there are these nodules and cords forming, and you can see some retraction of the skin, but there isn't any contracture yet. And the reason I'm highlighting this is that is where radiation therapy actually does the most good. Also, in the stage ones, early in stage one. So you see stage one actually goes from 0 to 45 degrees of contracture. Well, anything up to 10 degrees of contracture, radiation tends to be pretty effective, but beyond that, it loses its effectiveness. So once you're into stages 2, 3, and 4, not very effective at all, in fact. And you can, so in terms of risk factors, the modifiable risk factors, again, alcohol, smoking, good control of diabetes. So obviously you can't control whether you're diabetic, but you can control how good your sugar control or how good your sugars are. And also things that are very strong vibrational impacts and so forth. These can really contribute to worsening of Dupuytren's. So let's look at sort of each of the stages and what can be done. So for the very early ones where there are just starting to be nodules and cords, sometimes that is all that patients will get. It will just start and it won't actually progress from there. And so for those patients, it's best really just to watch. And if they start to progress, then radiation therapy is something that can be considered. But in addition, historically, the main things that have been used, splinting, stretching, steroid injections, but these are of marginal benefit. Radiation therapy actually, as I'll show you the data momentarily, works very, very well in this early progressive situation to prevent any further progression of the condition. More advanced contractures, that is greater than 30%, typically this is going to be dealt with in one of three different ways, which are all sort of surgical in nature. The surgical fasciectomy, which we can see a picture of one sort of before and after over here on the right. And that shows us somebody with a significant contracture, but that the operation to deal with that itself is actually fairly involved. That the recurrence rate at 5 years out from a surgical fasciectomy is about 20%. And this is much better than the other potential invasive approaches that include a needle aponeurotomy, which is basically poking a bunch of holes in that area of fascia and then doing a stretching that then breaks a lot of that scar tissue that is formed there. That works temporarily, but the 5-year recurrence risk is between 50 and 80%. So long term, it does not work great. There's something called Xiaflex, which is an enzyme injection, a collagenase injection, also with quite a high 5-year recurrence risk. And this is one that has a variety of other side effects that go along with it, and it really is not so commonly used anymore. Now, you can actually use radiation therapy in the post-procedure setting. And it does decrease the risk of recurrence. So you see from a surgical fasciectomy, you go from 20% recurrence at 5 years down to 10%. From the needle aponeurotomy, you go from 50 to 80% down to 17% in the studies that have looked at this. So a pretty significant improvement in the rate of remaining recurrence-free if you add radiation post-operatively or post-procedure. So you can see here, so again, when we're talking about early progressive disease, this is kind of the time when we do the most good, when the nodules and cords are growing, but when they have not really contracted the hand down. And you can actually see in this picture, somebody who's starting to have that sort of you can see in the skin that there's starting to be some contracture there, but the finger itself is still able to be straightened completely. So in that sort of stage N, which is what this is showing, the success, that is no progression at 5 years, about 87% for the use of radiation therapy. Once you're into that early contracture, the rate is about 70%. And then as you get into the full stages 1, 2, and 3 or 4, goes down pretty dramatically to the point where in stages 3 and 4, there's essentially no chance that radiation will be beneficial. So let's talk a little bit about what that standard radiation course looks like. Again, this is a significantly higher radiation dose than was used for arthritis and those other, and tendinopathies and so forth. It actually consists of 2 treatment courses with a 3-month break in between. So initially 15 gray and 5 treatments of 3 gray each, typically given on consecutive days. So say a Monday through Friday treatment course, followed by a 3-week break, and then a repeat of exactly the same course. So this is about half the dose that we go to for most cancers, but it's significantly higher than we go to for an arthritis. In early stage disease, again, success rate is going to be about 80 to 90% in terms of stabilization or improvement in the condition. There are, in fact, side effects potentially from this as opposed to low-dose radiation therapy where there usually are none. In the short term, mild skin redness and irritation, maybe some drying of the skin. About 25% of patients will get this. In a small subset of patients, 1 to 2%, there may even be severe redness and blistering of the skin. This tends to heal up quite quickly once the course is completed, but it's not unheard of to experience that. There could be also swelling of those nodules and cords, which can cause increased discomfort. Again, not a very high rate, but certainly I wouldn't call it rare. In terms of the long-term potential side effects, the most common thing by far is dryness of the skin in that area that's dry enough that it requires kind of ongoing use of moisturizers on a daily basis. But you can also have times when there is some change in the skin texture, where there's kind of a thickening of the skin of the palm, and it looks a little bit different, either from the thickness itself, or sometimes you get a little bit of change of color of the skin compared to what it had looked like previously. And that can be a permanent condition, though again, fairly uncommon, but not rare. And then rare radiation-induced cancers, but again, primarily this would be a skin cancer that would be the result of this, and a very long latency before that would occur.
So this sounds to me like a treatment where timing really matters in terms of radiation. Is there pain that comes with this during that stage 1, or is it just a visual change? Like
It is
what would your advice be to people to be able to recognize that and be able to be treated during that first stage?
Yeah. So first of all, it doesn't progress rapidly. So it's not
Okay.
like, oh, over a couple of months, you're going to go from where you could have done it to where you can't. It's a slowly progressing situation, but it tends not to really go along with a lot of pain. So really, it's the observation of those nodules and cords in the palm, and that the skin can start to pucker in that area. If you start to see that and you're noticing that things are changing, that is the point at which radiation can be quite effective.
Okay.
So yeah, so again, just to summarize, it's effective, non-invasive outpatient option for early active disease, can cause a halt or reverse the progression, or at least delay the need for any kind of surgical intervention. The side effects are usually mild. and it is most effective before there is any contracture that has occurred. Um, of course, with a lot of these things, it would be great if we had more randomized controlled trials or long-term follow-up, but we do have long-term case series follow-up, but it would be great to have some actual randomized controlled data for this, but really not much other than just case series data for this. Okay, shifting gears again, let's talk about radiation therapy for tremor. And we're going to talk just about tremor in general. And we're going to draw a distinction between Parkinsonian tremor, those tremors associated with Parkinsonism, versus what's called essential tremor, which is a tremor that really doesn't have any other associated issues related to it. So in the United States, there are about 1 million cases of Parkinson's disease at any given time. This is a progressive nervous system disorder, and it is causing its effect primarily by the loss of dopamine-producing brain cells. It is most common in people over the age of 60, a little bit more common in men than women. Its exact cause, not really known, but we think maybe there's a genetic component and an environmental component, and I think, unfortunately, a bad luck component as well. The most common symptoms would be slowing of movement, something we call bradykinesia, rigidity of movement, a tremor, which is true for about 70% of patients. But again, we think of Parkinson's as being something that everybody has a tremor, but in fact, about 30% of Parkinson patients do not have a tremor. It can cause a variety of issues with mood disorders and sleep disorders and cognitive impairment, especially as it gets to be very advanced, that can progress to dementia-type symptoms. And you can have a lot of these patients have bad issues with constipation and blood pressure issues and a variety of other things. In contrast, essential tremor, while it is a neurologic disorder with sort of an uncontrollable rhythmic shaking, it is not associated with any of those other issues the way that Parkinson's is. Again, the cause is not completely known, but there certainly seems to be an autosomal dominant. That means let's just say a familial component, a hereditary component. It is very, very common, 8 to 10 times more common, in fact, than Parkinson's. This is not a life-threatening condition, but it can be sometimes a debilitating condition. It typically starts kind of gradually, usually with hand tremor, but can sometimes have other areas involved like the head, and sometimes the voice. In fact, you can hear people have kind of a warbling voice as a result of this. That it can be worse in times of emotional stress, fatigue, and a variety of other things that just tax the system. Its diagnosis is essentially based on clinical evaluation. So the tremors are actually somewhat different between essential tremor and Parkinsonian tremor. In terms of the timing, essential tremor happens more when you're making intentional hand movements, where with Parkinson's, often you can see that the tremor is actually better with the intentional movements, but worse at rest. Essential tremor does not have those other health problems that go along with it, where Parkinson's does. Body parts affected. So for Parkinson's, again, it can start in the hands, but often involves the legs, the chin, and other parts of the body, where with essential tremor, usually it's the hands, the head, and the voice. The essential tremor tends to have a more rapid rhythm to it, whereas Parkinson's is kind of a slower, what they call pill rolling tremor, often seen where the thumb and index finger are kind of rubbing together in a rhythmic fashion. Treatments for them are actually quite different, especially from a medical standpoint. So because the issue with Parkinson tends to be the loss of the dopamine cells in the brain, that the level of these dopamine receptors can be upregulated, that the breakdown of dopamine can be suppressed by various medications, and just the release of dopamine can be increased and so forth. So what you're really dealing with Parkinson's is an attempt to manipulate the dopamine levels in the brain and thereby, if you can keep them more increased, then you can decrease the symptoms. On the other hand, essential tremor tends to respond better to things like beta blockers and anti-epileptic medications. So it's a completely different family of medications that you would use for essential tremor versus Parkinsonian tremor. Now, when medications cease to be effective, then we need to look to other ways of trying to control these tremors. The most common ways I'm gonna kind of go through with you briefly here. There is the use of deep brain stimulators, which is a very, very effective way at controlling tremors, whether they are Parkinsonian tremors or essential tremors. But this is a rather involved procedure that involves placing electrodes into the brain, then other things sort of routed under the skin to devices that are in kind of the upper thorax in the area like that you would see, say, like a like a pacemaker or something like that. Um, this is a very, very effective way for controlling tremors, but only about 10 to 15% of patients are actually eligible for it. And that has a lot to do with age, cognitive function, other comorbidities, and so forth. So a lot of these patients just are not going to be great candidates for deep brain stimulator, even though it is probably the most effective way of treating those patients who are eligible for it. And in fact, only about 5% of patients overall get this, meaning that about half to two-thirds of patients who are eligible for it decide not to do it because of the invasiveness of it. Now, it works by stimulating the subthalamic nucleus, or something called the globus pallidus internus, and it is able to be actually, the patient, when these are placed, is awake, and you can actually watch the tremors go away when you hit the right spot and apply electrical stimulation to that area. It is adjustable in that you can move where that probe is, and you can actually, now with more modern versions, you can actually change the direction of the impulse that's emitted from it to help kind of tune getting the optimal result from it. And so it is adjustable, and it is also reversible, meaning that if a patient wasn't tolerating it well, you could remove it. This is in contrast to some of the other things that I'll be highlighting in just a minute. So another approach for dealing with this same issue is something called radiofrequency ablation. This actually uses heat, or like a thermal lesion, in that same part of the brain to disrupt the signal there. The target is a very, very tiny part of the very deep brain called the ventral intermedius nucleus. We call it the VIM of the thalamus. This is done by putting an electrode into that area and heating that to a high temperature here, roughly 176 degrees Fahrenheit, and it will ablate a small area of tissue, and it will stop the signals from being transmitted there. The rate of success for controlling a tremor is somewhere 74 to 90%, so very, very good control. It is minimally invasive and requiring only a local anesthesia. Patients are awake during this procedure. The effect of it is immediate, as in you can see the results right away, but it's not reversible, as in you will ablate a small area of the brain and you can't undo that. Also, it's not adjustable, and you can't just move something the way you can with a probe that's in the brain. Side effects tend to not be very different from what they would be for a deep brain stimulator. You can get some balance disturbance, speech issues, the potential for some gait instability, but these are not very common. We now have available something called HIFU, high intensity focused ultrasound. This also uses a heating technique for basically ablating a small area, that same small area of the brain. This is quite effective as well, with greater than 70% of patients having good to excellent tremor control at 5 years out from their treatment. It is also immediate, and as in you see the results very, very quickly, but also not reversible and not adjustable. Same kinds of issues, balance disturbance, speech or gait difficulties, and the potential for some other things such as muscle weakness and sensory changes. But again, extreme side effects are not at all common from any of these. So let's shift gears to talk a little bit about radiation and its role in this, because this is fairly new. But what's not new is the use of focused high doses of radiation to small areas of the body, particularly in the brain or near the brain. Um, this is an approach called stereotactic radiosurgery, SRS. Some people call it stereotactic body radiotherapy, SBRT, or SABR, stereotactic ablative radiation. These are all basically using very high doses of radiation to small areas within the body. And we've used this in a variety of places. We treat prostate cancer, lung cancer, spinal tumors, and a lot of things in or near the brain with this kind of approach. Um, we at our program use a specialized machine called a CyberKnife to do this treatment, but you don't have to have a CyberKnife to do this. But it does deliver a very high dose of radiation using very few treatments. In the case of treating a tremor, we do this in a single treatment, but you have to have incredible precision and accuracy in doing this because you're using very, very high doses of radiation. So as opposed to what we were doing for low dose radiation or even for the Dupuytren's, this is much, much higher dose, therefore, if not done properly, with higher risk of toxicity. So this is a picture of our CyberKnife, which is a great machine for doing this kind of treatment. It basically, again, is high doses of very focused radiation, but there's no knife, okay? So the CyberKnife doesn't have a knife. It was named by a neurosurgeon, and I guess neurosurgeons feel like everything that's cool's got to have a knife. So there you have it. But it's completely non-invasive. Okay, but it allows you to do ablative therapy so ablative therapies are a little bit different than what we do for other radiation-based approaches. In other radiation-based approaches, say we're treating a cancer in a bunch of treatments, we are trying to leverage the difference in repair capability between normal tissue and cancer. And it turns out normal tissue can repair radiation damage way better than cancer tissue can. And so you give a bunch of treatments, and as you do that, the cancer accumulates more and more and more damage and it dies from the radiation, whereas the normal tissue fixes the problems and it just goes on acting like normal tissue. Ablative therapies kill everything in that target area, whether it's cancer, whether it's normal tissue, or so forth. So when we're doing something like treating for a tremor, we are trying to ablate or kill a very small part of the brain. This type of treatment needs to be done with a machine that can do that with incredible precision. So conventional treatment machines, technically, I wouldn't recommend using those for doing this specific type of treatment because its precision needs to be greater than what can be delivered by a conventional treatment machine. So really, a CyberKnife or another machine called Gamma Knife, which is kind of does very similar type of treatment, but with a slightly different approach. Those are the two radiation-based machines that are appropriate for doing treatment of tremors, but other machines really not so much. But again, these are ablative, very biologically potent. The potential for better local control of whatever you're doing, but because it's a very, very high dose to a very sensitive area, you have to do it with extreme care or you can cause toxicity. So again, this is a picture of the CyberKnife, and you can see it's basically a robotic arm. I don't know if you can see my pointer on there, but this is a robotic arm. It's actually made by the company KUKA, which makes all of BMW's robotic arms. So it is essentially the same robotic arm as used by BMW in their manufacturing plant, but instead of picking up car chassis or whatever, ours has a miniaturized linear accelerator attached to it. But it is designed to have an accuracy of about 0.3 of a millimeter. So an incredible precision in the delivery of treatment with this machine. Okay, so when we are doing this type of treatment, we have to immobilize the patient. But whereas Other approaches might use something called a head frame, where you have to bolt on a frame to the skull. The CyberKnife is able to do that just with the use of a plastic mask that fits over the face, or that's sort of molded to the face. And then any tiny little changes in position are actually accounted for by the machine itself. But with the use of this, again, very focused radiation that disrupts the normal signals that cause a tremor in that area of the VIM, the ventral intermediate nucleus of the thalamus. So with this, use a mask, no screws, no incisions, no anesthesia at all. It's completely non-invasive, and in fact, you cannot feel it when you get it. But it uses very, very high doses of radiation. So here we're talking about 130 to 150 gray in a single treatment. So again, even when I was talking about cancer before, I was saying, oh, 40 to 80 gray and 20 to 40 fractions. This, though it's treating a very, very tiny spot, it's doing it to an extremely high radiation dose. And this is what is required in order to ablate that area. It works very, very well with an 80 to 90% response rate, meaning patients getting good to excellent tremor control. But it is not immediate the way that the other approaches are. It takes time for radiation to cause that ablation. So typically 3 to 6 months from the time of the treatment delivery to the time you see kind of maximally what kind of response you're going to get. It is delayed, therefore, instead of immediate, also irreversible and not adjustable as all of those others, except for the deep brain stimulator were. Side effects tend to be very mild, a little bit of fatigue for a few days, the possibility of some nausea or dizziness, but those are fairly uncommon and easily treated with medication. Mild headaches have certainly been reported, but they respond just to over-the-counter medications. Rare complications would include brain swelling requiring steroids, paresthesias, which would be numbness and tingling kinds of sensations, the possibility of balance and coordination issues, and speech difficulties, though these are actually much less common for radiation-based approach than they are for deep brain stimulators or radiofrequency ablation. So again, 80 to 90% with complete or nearly complete tremor control 4 years out from treatment, mild side effects, and comparable effectiveness even to deep brain stimulators, but slower onset of symptom relief, again, 3 to 6 months. As with a lot of these newer techniques or approaches for dealing with benign conditions, most of the data comes from case series rather than randomized controlled data. So would be nice to get some more big trials, but certainly as the case series data accumulates, we're seeing more and more that these things continue to hold up, that it works very, very well and has quite minimal side effects.
So what I'm hearing here, Dr. Freed, is it seems like there's a lot of different trade-offs, right, with these different avenues of taking care of the tremors or helping to treat them. So it feels like one may work more quickly, one may be less invasive. So if I was sitting at home, I might would be wondering if I was talking to a friend, well, which one's the best one, right?
Right.
So, but
So
what I'm hearing is it doesn't really work like that. It's dependent upon the patient and the correct
yeah,
treatment for
so
them.
it has to, all these things have to be tailored very specifically to the patient, right? So deep brain stimulator, while we do consider it to be the gold standard, is only going to be appropriate for a very small subset of patients with tremor.
Mhm.
So now we're left primarily with these other approaches. Each one has pros and cons and really just requires a thorough discussion with doctors and patients to know that you're doing what's appropriate for that individual.
Great. I think I have one last question for you. If I was sitting at home, I would also be wondering, if I took something away from this conversation today, which I have a feeling a lot of people will, and they're wondering maybe they feel like they could be a candidate for one of these avenues, or maybe a family member would. What do you think is the best first step for them to learn more or find out if that's an option for them?
So there's a variety of things they can do. I mean, you can go online. We are actually in the process of getting a website together, which will try to summarize a lot of these things for benign condition treatment with radiation. you can go online and try to find some of these things, but I think it's best to really have discussion with physicians. So the starting point being to talk with your primary care doctor about these things. If you're really interested, you can have them refer you for discussion with us. The Also you can talk with your orthopedist about things like low dose radiation for arthritis. Some of them are very knowledgeable about it. Some of them haven't even heard about it, so you may be informing them about it. But I think it's always good for those doctors to be involved in all of this from in thinking about um, Dupuytren's. A lot of times these folks have seen hand surgeons and have been told, it's not bad enough yet that you need to think about surgery. Those patients actually are probably very good patients to be thinking about radiation therapy. I've actually spoken with some of our hand surgeons locally about this, and because again, sometimes we might delay the need or prevent the need for surgery. Sometimes, though, it may be an adjunct to surgery to make their surgery more durable and more effective. So again, collaboration is always better than doing things kind of in isolation. So I think, talking with primary care doctors and orthopedists and so forth, when we're thinking about tremor, we're going to be talking a lot with our neurology colleagues to get them on board and understanding this. And a lot of them I've already spoken with, even though we're just sort of at the outset of our program for doing this kind of treatment, but I've spoken with a lot of them who have kind of exhausted the medical options. They're not comfortable with a lot of the other potential interventions. And so this is going to be, I think, a good option for a lot of their patients. So again, they can go, the patients can go to their primary care doctor or to specialists and have a discussion about this and ask for a referral. But they can also contact us directly and we can get them in if they don't feel comfortable talking with their other physicians about these issues.
Great. Thank you for the information. I have to say, Dr. Freed, thank you again for being here and sharing your expertise with us today. This was really great. I hope that you, as the audience, enjoyed this as much as I did. I feel like that hour just kind of flew by, honestly. I learned a lot of really informative things, and I'm really excited to be able to house this on online so people can refer back to this information. So I'm sure you out there as well, you learned a lot today, and we hope that you did, and maybe that you'll consider treatment options differently moving forward from this information. So thank you again for being here and for helping us understand this important topic. As always, we do want to leave you with a quote to carry with you throughout this month until we meet again for our next session. The true sign of intelligence is not knowledge, but imagination. And that comes from no other than Albert Einstein. So we hope that you'll join us next month for Cancer Survivors Park Prevention and Wellness Series presentation when we'll be talking about navigating financial barriers. Thank you so much again for joining us, everyone. And until next time, take care and be well.